a little bit about our model and what it means to integrate bio-neurofeedback into that model. So just as a recap, we'll talk a little bit about what integrative mental health is, and along with that, the comorbidity of addiction. I'll give you some of the basics of bio-neurofeedback, and then we'll talk about specifics. How many here are familiar with biofeedback and neurofeedback? Fantastic. Right. So our founder, his name was Bill O'Donnell, and in the 80s he founded Sierra Tucson because he had such a great experience with his own recovery. And when he developed the hospital, he had this notion that an individual was more than their disease, that they were more than their addiction. And he envisioned a philosophy that was the mind, body, and the spirit. Around that time, at an international epidemiological level, research in health-related quality of life started to be developed with the World Health Organization. And this construct, looking at the physical, the psychological, and the social components of health and illness, were also being developed in parallel, which is very interesting to me. So when we think about this sort of health-related quality of life, it really begs for us to speak about this new movement away from traditional allopathic medicine into what we're calling now today's integrative medicine. Are you familiar with the term integrative medicine? Okay. In 2009, it wasn't that long ago, the consortium of academic health centers finally identified and defined what integrative medicine is. And this is a lot of the work from Andrew Weil and those sorts of individuals from the 80s and 90s. So the aim of integrative medicine is to focus on the whole person, not just on the symptoms or the disease, and to really take hold of what it means in terms of the relationship. So not only the doctor-patient relationship, but the therapist-patient relationship. There is research to show that if you have a good alliance with your patient, they will do better in recovery. So there's something about that satisfaction and that rapport building. In grad school, we used to call it the non-specifics of therapy, like it was some sort of, confounding factor, but now they're finally giving it its due, which is important. Integrative medicine also makes use of the diverse range of appropriate therapeutic approaches, and they should be evidence-based. So this is a lot like the CAM. You've heard of CAM, the complementary alternative medicine. Well, now this is being woven into what we call integrative medicine, and the end goal is to achieve optimal health and healing. A year later, integrative mental health was then defined, and this was done by the International Network of Integrative Mental Health. It's very, very similar to the integrative medicine model that we are looking at the whole person, and this is also looking at just not their mind, body, but their interrelated systems. And I like that because we're really looking at other factors going on. Considering the therapeutic alliance, again, just like integrative medicine, and once again, using appropriate therapies, or we want to meet our patient where they're at. And another dirty word we learned in grad school was called eclectic therapy, right? We were not allowed to be eclectic, but now it's what everyone does basically, right? You meet the patient where they're at. The goals here is maintaining a healthy lifestyle, or at least achieving one, and looking at so many more other factors than just recovery from what it is they're coming to see you with. So when I think about integrative mental health today, and then I go back in time and look at what Jack O'Donnell had developed, and then the health-related quality of life model, it truly is what I would call today's integrative mental health. So way ahead of their time to the present. And that's basically what we practice here at Sierra Tucson. So how would that model help individuals who are struggling with addictions? Well, the question I have really is, what is the etiology of addiction in the first place? So if we just think about what the etiology may be, many of us were wondering if it's a hijacked brain. I'm sure you've heard that term before, right? So is there some sort of neurochemical imbalance in the brain, or is it purely genetic, right? Some of the correlational studies showing that fathers can pass on an addiction gene to their son. Is it psychological? Do we have individuals who just aren't strong enough to say no? Or are they using drugs to cope with stressful lives? More of the self-medication theory. And then finally, socially, are we using because we want to fit in, or do we have social anxiety? And so if we think about this, it really does beg the question that addiction is not just occurring in a vacuum. It's not your fault. It's not the fault of your genetics or a predisposition. It really is a comorbid process. And along with addiction, as most of us know in this room, we were struggling with patients who have depression or anxiety or a history of trauma. And so there's more going on in addiction. And so using the integrative mental health approach is very appropriate in treating our patients. The American Society of Addiction Medicine actually defines addiction as this: is a primary chronic disease of brain reward, motivation, and related circuitry. So there's that brain piece. There's a dysfunction in these circuits that lead to biological, psychological, spiritual manifestations, which is reflected in the individual pathways pursuing reward and other behaviors. And is characterized by an inability to consistently abstain, impairment in behavioral control, craving, basically a dysfunctional emotional response, correct? Would we all agree to that? So if I pick this apart, I see that ASAM identifies the biology, the psychology, the social, and the spiritual in their definition. That's integrative mental health. They also talk about their behaviors and interpersonal relationships and that emotional response. So in this beautiful definition, they are capturing the fact that addiction does not occur in a vacuum. Therefore, it shouldn't be treated in one either. So what we have at Sierra Tucson, we have 5 major treatment tracks. Addiction, and we always call it addiction co-occurring because there's other issues coming in for these individuals. We also offer tracks for mood, trauma, complicated pain, and eating recovery. And it's not unusual for us to see individuals participating in these programs who are also struggling with some form of addiction, whether it's the eating disorder patient who's using a little too much stimulant medication to lose weight, or the complicated pain patient who has an opiate dependence. So there's comorbidity all over the place. And so each individual needs to have that targeted, integrated treatment. So how we do it? We have psychiatry and primary therapy. These are the pinnacle head of our treatment team. We have the treating physician and the psychotherapist. Along with that, we have a psychology department for assessment. We do have a family program, so bringing in that interrelated system into the therapeutic atmosphere, psychoeducational groups, and recreation therapy, getting in people moving and bonding and trusting one another. And then our integrative therapies. So there's a whole host of integrative therapies that I won't be able to touch a lot on here, but these are a complement to the primary programming, which is pretty typical of a lot of rehabs. Here we have EMDR offerings, somatic experiencing, equine assisted therapy, body and energy work. Believe it or not, we do a little woo-woo, but it's also very comforting. Acupuncture and naturopathic, and then of course the Neurofeedback program. So I'll talk a little bit about the biofeedback now. So according to the American Association of Applied Psychophysiology and Biofeedback, biofeedback and neurofeedback are a process that enables an individual to learn how to change their physiology for the purpose of improving their health or improving their performance. What we have are medical grade equipments, and I actually brought mine because I did a little recording earlier today, and it's truly medical grade. So we're looking at heart rate, we're looking at perspiration of the hands, skin conductance, we're looking at brain wave. And what we then do is put this in front of the individual on a computer screen, and it feeds back to them. That's where the feedback comes from. So they learn how to gauge and associate their physiological experience with their emotional experience. Okay. So that is the essence of neurofeedback. Over time, these changes can endure without continued use. So again, that operant conditioning paradigm. Remember Pavlov's dogs? Well, that's what we do in biofeedback. So it really is this operant classical conditioning that's become clinical. Yes, sir?
Over time, what does that mean? Time means how long? Over time?
Over time? It depends on the individual. It's a very good question. Some people...
During the course of a treatment episode? During the course of an inpatient treatment episode?
Mm-hmm. Yeah, and if you read some of the articles in the literature for certain conditions like attention deficit per se, maybe 20, 30 sessions. For some individuals with help in coping with depression physiology, maybe 5 sessions. It really depends on what you do and the resiliency that your patient comes with. So what we want to do here is show you the evidence-based findings for bioneurofeedback. And number one, it's to enhance one's stress coping. Huge piece for our addiction population. It's a huge piece for all of us, I think, in today's world. There are articles to support its significance in helping with body pain and headache. There's a special device called a hemoencephalography that actually helps with migraineurs, and it works. It's really quite remarkable. It helps to improve sleep quality, reducing cravings and compulsions, very important for our patients. There are some studies that show that biofeedback and combined with neurofeedback can help lift depression out of the body, improve concentration and focus. So a little history, and I'll be very brief about this. People think that bioneurofeedback is relatively new, but it's been around an awfully long time. Actually, in 1865, Claude Bernard, a French physiologist, actually was working with gut research, and he realized there was something about a constancy of the internal environment that led to resiliency and health. And it was many years after his death that his students actually coined the term homeostasis, and I'm sure we've all heard homeostasis in this room, right? In 1877, Russian physiologist Davilevsky actually identified the nerve impulse in the brain. So he was actually able to start recording that back then. In 1908, Edmund Jacobson from Harvard developed a tool to measure muscle tension, the EMG or the electromyography. And he started to use systematic desensitization measuring EMG. And that was over 100 years ago. So there were pioneers in this field. Hans Berger out of Germany added on to Davilevsky's work and developed the EEG or the electroencephalography. And the first brainwave he recorded was alpha, which he called alpha. But alpha is actually one of the most middle waves, but it was the first wave he saw on the screen. He said, number one, it's alpha. So that's why it got its name. George Mandler out of Yale, as a physiologist, identified that an individual's physiology could be trained. So he started some of the early work on retraining physiology. And then Joe Kaimea of UCLA was able to show that you could train alpha frequency in the brain. So he was starting to do early neurofeedback studies. So it looked a little weird, I would imagine. It took me a while to find these photographs, but if I were to see a setup like that today, I would be like, are you kidding me? It was a little terrifying. I think this guy's sitting on pins actually, or needles. So it doesn't look like anything like that today. It's very streamlined, very clean. These are samples of biofeedback. You can see he's looking at his screen there, and these are examples of neurofeedback. This gentleman is wearing a full cap for a full QEEG, which is quantifiable electroencephalography. This field is burgeoning like mad right now, and some amazing dynamic treatments are being done using full cap training. This young woman has one lead placed right at the top of her head, which is typical for attention deficit training. And yes, it's legitimate. It's no longer considered woo-woo, thanks to computerized graphic development, actually. In the old days, you saw those big gauges and dials. I mean, that's how biofeedback was trained. So you're basically looking at a dial saying, well, move the arrow over to the left side, and then you're doing your biofeedback. Today, it's computer interface. It's very engaging. We have many gamers, right? And so a lot of the games that we play doing neurofeedback look just like you would do on their Xbox. Still not as pretty, but it's getting there. So it's legitimate. These are our governing bodies. They're international and American. And we also have our own host of peer-reviewed journals in science. So biofeedback. Its primary focus, anyone want to guess what it is? The body, okay. So the primary focus for biofeedback is looking at the biorhythms as they relate to stress. And primarily looking at the autonomic nervous system. The EMG is going to be looking at the somatic nervous system, the muscles. Most of it is autonomic nervous system training. So the clinical indications for biofeedback, number one is to help patients learn to reduce stress. And they do this by learning what their bodily cues of stress are. I don't know if you engage in this in your own therapy, but many patients aren't even aware that they have a stress response. They're so used to living in a chronic state of stress that they're unaware that the huge muscle tension in their shoulders is an indication that they're carrying a lot of stress. Or they always have cold hands. It's a perfect example of chronic stress. We also teach them to learn how to initiate that relaxation response, and I'll talk a little bit more about that. We also use biofeedback for stress management. So this is really the habituation or the practice that's involved in not just learning to reduce stress or handle it better, but then to build resiliency in the physiology. So this takes a little bit of practice. And resiliency training is also tapping into the heart. And I have a sample to show you what that looks like, and it's actually really cool. So how does this apply to addiction? So A.B.L. Goodman, a couple 20 years ago, identified addiction as that external action in order to regulate an internal state, right? So basically he said, we're motivated to use to feel good, or are motivated to use to reduce that state of tension, right? We're trying to keep balance. And if I don't know about you, but to feel good and to feel better, to balance that state of internal state, sounds a lot like tapping into that autonomic nervous system. Really looking at homeostasis, trying to get back to that state that you know you'll be most comfortable. So addictions patients definitely benefit from biofeedback. Another reason why is the issue of stress. So these are just a few articles. If anyone wants copies of these, I'd be happy to share with you. And we're going to start a piece of paper around here if you want any. If you want my presentation copy or the articles, please write your email down for me. But Terry McElrath and her colleagues identified that the primary reasons for youth in America to use, again, is to feel good or to feel less tension, which is in response to stress. Koob talked about the amygdala and addiction, and he's speaking mostly about that HPA axis, where that the reward pleasure system. That same system is involved in our ability to manage stress. So when we become stressed out, that same system is triggered that releases those corticosteroids into the body. Sinha talks of, this is a beautiful review article if anyone's interested in this, but he takes you through the whole experience of what it means to become addicted as a stress indicator and the challenges of recovery. So stress is not only a predictive feature for becoming addicted, it's also a predictive variable on whether someone stays active in their recovery or not. So stress really does play a huge role. And Vitkevich from UCLA talks about using mindfulness training for patients to maintain a healthy recovery, and how mindfulness really is about stress management can be beneficial. So let's talk a little bit more about biofeedback itself. So remember, we want patients to identify and learn about their stress cues. You can't fix something if you don't know it's there, right? So number one, let's see how your body is manifesting stress. Then we learn how to elicit our own relaxation response through training. And then with practice, rehabilitate our physiology towards resiliency. The idea for me, and I tell this to patients, is getting to a place of responding to events, not reacting. Do you see the difference? Okay, it's very, very important. Homeostatic environment is responsive. The chronic state environment is reactive. So really moving that physiology to become more dynamic. So what are we measuring? So we're plugging in patients to check their breathing, and we use a pneumograph for that. Heart rate is measured by a photoplethysmograph, so if you can say that 5 times fast, it'll be $5 American bucks. Okay. Peripheral temperature is measured by the thermistor. Muscle tone, the electromyograph. Skin conductance, the electrodermograph. Big words, but this is how we're capturing real physiological functioning. Now, as therapists or treaters, you don't necessarily have to have a biofeedback equipment to sort of tap into where your patient may be in a given moment. So when we're stressed, respiration tends to be shallow, rapid, or many of our trauma patients hold their breath. They forget to breathe. Some people are saying, yeah, right? Maybe you catch yourself stopping breathing, okay? Heart rate tends to be fast and attenuated. Attenuated means there's not a lot of flexibility in the heart rhythm itself. I'll talk about that in a little bit. So it's constantly beating, 60 beats a minute, 1 beat a second. Peripheral temperature is cold. We do not need nourishing blood in our fingertips and toes or our gut when we're under stress. We need all of that blood to go to our big muscle groups in our gut, right, to take care of ourselves. Muscle tension is tight or tense. Skin conduction tends to be clammy. When we're relaxed, clearly we're going to have more of a slow, even breathing. Heart rate will become rhythmic and prosodic. Lots of swing in the heart rhythm. Warm hands, toned muscles, and then dry hands. Yes, ma'am?
Is this the same equipment that's used in testing people telemetry?
Yes, it is. Yeah, so the lie detector test, what they're looking for are little nuances in the tension that is surrounded by lying. So if you're telling the truth, you're not going to have a spike in your heart rate or, a micro measure of moisture in the hands. But the interesting thing is clammy hands is not all of us experience. It's actually a vestigial response. So not all of us have that. And you can trip a lie detector too. So how does it work? Here's an example of a screen, okay? And what we're doing here is we're trying to have someone who has clammy, cold hands, okay? And so this is the warmth of the hand, this is the wetness of the hand. And you see these little lines? So we engage as the trainer or the therapist, you're constantly moving those threshold lines to train, shape the right response. And we're basically saying to the patient, okay, you're hooked in, we're looking at your clammy hands, your cold hands, make the sun rise. Now, we're not going to do this on the first session. We're going to orient them and they're going to do some techniques and it's part of the therapeutic process. But what we want to do then is have them decrease this sweaty hand. So their hands are sweaty, their hands are relatively warm in this sample. So these are rewards and inhibits. So they're encouraged through active volition or passive volition to get that sun to rise. And when the sun is rising, you're encouraging them to feel good, to feel joy, excitement. They're doing something, right? That's the reward piece. The sun not rising is a natural inhibit. So with time, you can see that the sun has gone up and the temperature has gone down. And that's kind of it in a nutshell, right? That's a very simple example of that. When I orient patients, I always talk about the psychophysiology of stress. And I'm always happy to share this graphic with my fellow colleagues because what I notice in talking about this natural tendency of the human being, a lot of times patients feel so much relief that they are not the sole reason that they have an addiction issue. And I'm not kidding. I'm just talking about this with patients. They can tell me their story based on their own physiology. So I'll just show you a sampling of how I do that. So this is an animated graphic. I'm happy to share it with anybody. But I talk about the autonomic nervous system, and that's the system that controls all of our involuntary organ functions. And it's also responsible for our energy, right? How alert we are, how relaxed we become. We have the two divisions, the parasympathetic and the sympathetic, that's sort of on this continuum. And we talk about homeostasis. So I introduced the concept of homeostasis where we have a lot of this parasympathetic and just a little of the sympathetic. But then I add a twist because it's not static stasis, it's actually dynamic. So I prefer using the term homeodynamic because homeodynamic state is a responsive, resilient, flexible state. So this is our normal. In fact, it's the normal for most any living being. So, but we are designed to move out of homeostasis when there are times of threat. So you can have the proverbial tiger chasing you, or you could be stuck in traffic very late for an important interview. Either way, that's a stress response. Brain perceives that, pushes us into that sympathetic state, right? This is a high energy state, or otherwise known as the fight, flight, freeze state. The symptomology here is the quickening of the heart, the breath, the changes in the vascular system where the hands getting cold, our digestion stops, we get sweaty, right? Physiologically or psychophysiologically, this is panic, anger response, and impulsivity. Impulsivity. Think about our addictions patients. Right? As soon as we perceive to be safe, we got time for the job interview, the brain perceives safety, and we go back to homeostasis. So this is generally how this is designed. We're homeostatic most of the time, we move into high gear to take care of issues, and then we get back. But then we enter something called 21st century lifestyle. And I would imagine 90% of us in this room are dealing with chronic stressors, whether it's financial, it's our business, it's a bad marriage, whatever it could be. Most of us have moved from this calm and alert to a chronically stressed state. A lot of times we don't even know we're in it. Now, Hans Selye, the 50s, actually developed this model of the chronic stress and crash. And it took the American Medical Association to the 1990s to finally acknowledge that stress illnesses were real. And stress illnesses today are considered heart disease, our GI issues like irritable bowel, headache is also considered a stress disease and whatnot, or stress illness. Psychophysiologically, which is important to us in this room, we have irritable, anxious, impatient patients. So think about your own caseload, right? These are people who are chronically stressed. And now we start to make the connection. Oh, you mean I'm not a cranky person? Really? That's not my personality. It's just that I'm chronically in this stress state. So patients start to have this kind of awakening that their mood is not this ephemeral experience somewhere. It's actually lodged in the body, and it's manifested by our organs and how we are reading our physiology. So if we cannot get out of chronic stress, the research of Hans Selye and Seligman showed that if we cannot get out of this chronic stress state, the body will flip a switch and throw us into this crash state. Okay, so Selye called this the stage of resistance. Crash is what he also calls the stage of exhaustion. A little bit of a review for you. Overactive parasympathetic state is not a typical place for the human to go. We go here to recover from too much stress for too long. Symptoms here are feeling exhausted, fatigue, burnout, maybe lacking motivation. Sounds a lot like depression to me. So maybe some of us have in grad school where you're busy with the finals week and you have papers to do and exams to take, and you do your last exam and boom, you get the flu. Has that ever happened to anybody here? Okay, that's a perfect example of being in this state of resistance, and it's all over, and then you got the crash, right? I tell patients, it's no wonder to me why so many of us have both a diagnosis of depression and anxiety simultaneously. It's really the physiology just trying to right itself, right?
So, can you fluctuate between the two during the day, for example?
You can have both, in a way. So to talk about it and to present it, it has to be linear, like two-dimensional. But there's much more to that, right? I'm going to show you an example of having stress and fatigue at the same time, and that's really uncomfortable. You know, most patients who are going through detox are really anxious and they're exhausted. It's a very, very uncomfortable state to be in. Yes. When we achieve homeostasis, I like to think of us having that long, healthy, and happy life. It makes me think about Tibetan monks. They live forever, and they're very simple and happy and healthy, right? But there's something about maintaining, having that sort of monk lifestyle that keeps them healthy. The other thing I also tell patients is you cannot be homeostatic and stressed at the time. So you can be both fatigued and stressed, but you cannot be fatigued and homeostatic or stressed and homeostatic, okay? And that's good to know. It's something that's achievable. So what I'm going to do here is I'm going to show you an example of how this works. Okay, so this is an example. I actually did this on myself this morning to show you. This is my heart rhythm, okay? So that's a 72.5 beats a minute, that's 65 beats a minute. The heart is not designed to be steady. It actually wants to fluctuate. This is my breathing, and I'm actually breathing pretty fast here. I'm breathing 2 full breaths in 5 seconds, so that's a 2.5 second breath. That's pretty rapid. This is my autonomic nervous system. So this graphic is developed by reading heart rhythm, and it's a fast Fourier transformation of the data. It's really high mathematics. But what we're looking at is an extent. This red band right here is measuring how overactive is the parasympathetic, and this tiny band here is measuring how active is the sympathetic. Homeostasis is between these two bands. So I'll tell patients, you want a skewed bell curve. This is flat, the mountain is here, and all of that is flat. And honestly, I am jet lagged, right? So I wasn't surprised to see a lot of poop over here. I'm pretty tired. And I'm feeling a little stressed because I have to talk to you today, right? So I decide at this point in time to show you what it means to practice heart rate variability, okay, and what happens there. So I'm still breathing rapidly, but now I'm going to start paying attention to my heart. And as it goes up, I'm going to breathe in. As my heart starts to slow down, I'm going to exhale. And now you're going to see we're going to move away from this attenuation to this very dramatic change in heart rhythm. Do you see that? Okay. My physiology is relatively homeostatic, right? It was very stressed and fatigued. See how it's changing, right? A lot of this is paying attention to the heart. Heart rate variability biofeedback, I would encourage everyone to learn this and to learn and teach it to your patients. Your heart is directly connected to your limbic system via the vagus nerve. There are more afferent neurons leaving the heart to the brain than the other way around, which always makes me wonder who's really in charge. So as I become homeostatic, there are signals being sent to my brain like, hey, there's nothing to worry about down here, we're cool, right? Brain's like, oh, okay, reabsorbing corticosteroids, getting into harmonious balance. So there's a very strong connection here with the heart. We learn how to get there through breath because heart and breath are very intimately connected. So it's pretty cool stuff. Any questions on this? Yes, ma'am.
Is this the same as heart math?
Heart math, yes, absolutely. Now, this is different, the fact that this is my true heart. And this is why I like this one better. Heart math, you have a simulator, right? And you set it to 10 seconds, 5 up, 5 down. And so you have an individual breathing along with their heart with the simulator. I think it's good as a practice tool. But what's key is really learning what is your rhythm. Because your heart rhythm is like a fingerprint. It's unique to you. So, we can calculate mine right here. Let's see, about 3, this is 5 seconds, that's 10 seconds, right? So I have maybe a 3-second gap after my heart slows down, maybe a 2-second pause at the top, right? And 1, 2, 3. So my heart 3 seconds up, 2 seconds at the top. Oh, it just ran on its own. And so what we do in our therapy is we actually map the typical heart rhythm for that patient. And then we send them home to practice their heart rhythm. And then you don't need the heart math once you learn what your heart is. Make sense? Has anyone else used heart math before? It's quite nice. It's a lot cheaper than what I have, so that's one reason to get it. You were gonna ask a question?
Just bottom graph here again. Is that just showing the homeostasis?
Sorry?
You're saying the bottom. So you've got the heart rate, the top, the breathing, the second, the third is the.
Yeah, so this is just sort of it's not even a training screen, it's a report screen.
Yeah.
And it's just showing heart rhythm nature, right? Respiration. And then we start to see the change where the idea is coherence. We call it coherency, where heart and breath go together. When that happens, the body's homeostatic. In my case, not 100% because I'm still pretty tired, but I did the best I could.
So you're doing the heart rate off a finger pulse oximeter on that?
Yeah, that's the photoplethysmograph.
Yeah.
Yeah.
Do we-
I lost it.
Do we
Yes.
know for sure that corticosteroids are reabsorbed in that process?
That is the theory. Absolutely.
It's a theory.
It's the theory.
Yeah.
Well, you know, there have been studies done. To do psychoneuroimmunology studies is not fun because you have to wear a cuff where it's constantly drawing blood. So when there's the absence of corticosteroids, we have to assume they're reabsorbed, right? Yeah. I can do it. Where's my clicker? Here it's okay. Great. Okay. So indications, initially for biofeedback, is to quiet the overactive or stimulate the underactive, right? So it's stress awareness, reduction, and management. That's how I approach it in my work with patients. So where can you start with that? With breathing. Okay, these are just some samples. How many of you here use breath work with your patients, right? There is a science to breathing. Email me, there's a wonderful article that I do share with patients to show why breath work actually does change the physiology. And it's that sample that I just showed you. It taps into the heart rhythm. Once the heart becomes coherent or prosodic, the physiology becomes regulated. The nice thing about hooking someone up to a biofeedback machine is to find out if that breath technique really works for them. You know, just because Andrew Weil says 4 or 5 sevens are the breath to do doesn't necessarily mean it's going to work for everybody. So we test that with the equipment and we find out what their breath rhythm is to practice. So the focused breathing techniques, no more than 2 minutes, can really help individuals. Autogenics is what, are people here familiar with autogenics at all? It was developed in Germany at the turn of last century, and it's a system to help with sleep. People who cannot get to sleep, have chattery minds, and it's a wonderful self-hypnosis of sorts, I guess you'd say. But it's the breathing technique they use is whatever you breathe in, you double count for the exhale. So breath is correlated to the autonomic nervous system, and so is heart. When heart beats faster, when we're breathing in, we're triggering the sympathetic nervous system. So think breath is life, energy. When we're exhaling or the heart is slowing down, that's tapping into the parasympathetic nervous system. So if you're stressed out, you can try this. You breathe in for 3 seconds, maybe 4 seconds, and then you exhale in 6 or 8 seconds. You'll notice a quieting take place right away. And so we teach this to patients so they can learn to cope with stress better than reaching for a drink, right? They're tapping into their own resources here. Mindfulness breathing can be very beneficial, especially if you do a little bit of hypnosis work. This is the breath awareness that John Kabat-Zinn also developed, and then the heart rate variability training, which I showed you a little sample of. So we start there. So let's talk about neurofeedback, and then we can talk as we go. So neurofeedback is brainwave measurement, and again, the same sort of feedback loop. You're seeing your own brain waves, your own brainwave patterns, and making changes based on operant classical conditioning. And so we talk a lot about these brainwaves, delta, theta, alpha, beta, gamma. You've heard of these before? Okay, and so they have their own sort of characteristic. So primary focus is brain. I gotcha. Okay. So neurofeedback is biofeedback for the brain. Okay. What we're looking here is the cortical electrical balance. And so we're tapping into the autonomic nervous system, we're tapping into the central nervous system here. There has been over 40 years of research, good research. It started out shaky, it's getting pretty good now, where we're finding that our brainwave patterns are unique to neurochemical structures and neuroanatomical processes, abilities. So when the brain is harmonized or synchronized and the frequencies are in good relationship to each other, because we're looking at ratios, we're not looking at alpha alone, we're looking at alpha in relationship to beta or in relationship to delta. We have cognitive flexibility, impulse control, natural learning, and calming responses. Think about your addictions patients, right? Impulse control is key. In balanced brainwave relationships, we do have a nice library of articles to show ADD is in a very much an imbalanced brainwave pattern. Autism, this is some of the earlier work. Mood instability is really more of a hemispheric instability, which is actually quite interesting. Non-restorative sleep and addiction. So there's quite a few articles that are being published now to help patients with addiction through neurofeedback. Neurotherapy then is basically reconditioning or retraining these cortical electrical activities. And we do it the same way that you saw the biofeedback. So patients are learning to see their own frequency imbalance, and then they start to pair it with their own sort of cognitive experience. So they do this through passive volition, and this really becomes the mindful awareness of conscious states. And I actually love this. Dan Siegel wrote a book called Mindsight. Anybody read that? Okay, it's a wonderful book. It's an easy book to read. And he calls the sixth sense, not as ESP, but the sixth sense is being aware of your conscious state in any given moment. And we can achieve that with neurofeedback, and it's very powerful. So the National Institutes of Drug Abuse defines addiction as a chronic relapsing brain disease, so they're really focusing on the brain there, characterized by compulsive drug seeking and despite harmful consequences. They consider it a brain disease because the drugs change the brain, changes its structure, right? Changes its chemicals. And we know it changes the electrical firings of the brain as well. So this is the hijacking of the brain's pleasure reward system. And in other words, addiction is a conditioned change in functioning. I tell patients, you've done a great job conditioning your brain to be addicted. Now our job is to condition it not to be, right? So it puts the power back into their hands. So the neurochemical pleasure reward system, I'm sure many of you are familiar with this. You know, subcortically, we're looking at that piece where we experience something that is deeply enjoyable at the brainstem and the deep subcortical structures. And that reward pleasure then sends dopaminergic pathways through the insular cortex, where we have that interoceptive response or experience of how good the body feels when I drink wine, right? And then that dopaminergic pathway goes all the way to the frontal lobes, where I'm thinking, I need to remember that next time I'm stressed out, right? And so we have that sort of pleasure reward system at work here. This is very much a neurochemical model for the hijacked brain with addiction. But when we look at neurofeedback, we need to overlay something called the Broadman areas on that system. Are you familiar with Broadman here? Okay. So we take Broadman and all the characteristics, we apply it to the 1020 EEG system, which I'll show you in a little bit, and we're really looking at the neuroelectrical processes involved, okay? So brainwave characteristics, let's talk about them real quick. So when we talk about gamma, gamma is a very, very, very fast frequency, okay? And gamma is a bursting frequency. So we don't really measure gamma that often, but it sort of bursts from time to time, especially when we're feeling elation or we're feeling deep connection, whether it's to a loved one, a baby, or even to our God, right? That sort of euphoria, those are gamma bursts, if you will. When gamma is hovering at a measurable amount, or maybe too much, we start to see people with panic or frets. Also OCD, just that fast rigidity. Beta. Beta is, are you all familiar with beta? So beta is bright. When we're in a higher beta state, we're paying attention, we're engaged, we're learning, right? We're planning, we're controlling our impulses. When this becomes stuck or too high, we start to see a correlation to anxiety and a tendency to worry. Just can't turn that brain off. I've had patients tell me it's like gerbils, gerbils running in a little, whatever the thing is, their wheel, right? Can't turn it off. Sensory motor rhythm is very unique and special to the sensory motor strip of the brain, and this is a good place to train athletes, attention deficit, okay? And it's also called low beta. But we're calm and alert. This is the zone that we feel when we're doing athletics, okay? Or if we are doing some sort of high, a high profile or high intensity sport, you get into that zone. When SMR is off balance, especially in relationship to slow wave theta, we have problems with attention deficit. And when it's off balance to fast wave beta, we have issues of insomnia. So we can train at the crown for those issues. Alpha, the first wave ever discovered, When it's a dominant state and it's flexible, and it should be very flexible frequency, we're relaxed, we're meditative, and we're receptive. When we smoke pot, we feel alpha. And that's why it's so attractive. It just feels really good. But the cool thing is that you can train your patients to feel alpha without a substance, and that's pretty remarkable in itself. Alpha, when it's,
quickly,
what's that?
now that cannabis has got so much stronger, is that still the case?
Well, you know, it's hard to tell now because it's laced, right? There's so many factors that are ingredients that are lacing with, I don't even know what we're looking at anymore. But in terms of natural stuff that, you know, the guy down the hill would grow, right? It gives you that really awesome feeling. A glass of wine is going to put you into an alpha state as well. The problem is your brain learns to associate that quietness with the substance. What we want to do is retrain your brain to take on that, to do it on its own, right? Too much alpha, a little daydreamy and distractible. So alpha is actually part of the attention deficit continuum. The big one for attention deficit is theta. Okay, this is a sleep wave. Okay, but when we are awake in the theta state is where we go with hypnosis. So anyone do hypnosis here, and you do it well, you're taking your patient to a trance-like state. That's theta. And when you are conscious and in a theta state, this is where a lot of sort of insight processing can take place. It's very blissful to be in this state. There is a neurofeedback program to help alcoholics actually get here more often. And it's great because then they start to realize they can get there without alcohol. But theta is a biggie in the neocortex. If you got too much of it, you've got attention deficit or you're impulsive. Delta is our deepest wave that we're measuring today. We're starting to look at subdelta frequencies. Delta is a true deep sleep wave. We rarely see it being active in the normal waking adult, but it is present with TBI and the dementing process. So that's usually our cues to look into that. So real quickly here, there's your Broadman areas, and how we look at Broadman is the characteristics of those structures. And so this is the frontal lobes, where this really separates us from our mammal brothers and sisters, is that frontal lobe, because this is where we can think, this is where we plan, control our impulses, and attention and focus. And it really is initiating the learning process, right? Communication. The characteristics we look for in the EEG waves is a nice ratio of about 1.5 theta to beta at the frontal lobes. When we have this nice balanced relationships, we are sustaining our concentration, we're alert, engaged, hopefully how you are now and I'm now, right? If we have too much fast frequency dominating at the frontal lobes, then we're starting to look at symptoms of anxiety and agitation, impatience, maybe some chronic stress, right? And the opposite, if beta is deficient or too much theta, then we see some traditional symptomology for attention deficit. So they're distractible, they're impulsive. This is also not unusual to see with our addictions patients, right? And we know that pleasure reward hijacking takes place where the frontal lobes become a little bit offline. So there's a lot of relationship there. When we have too much alpha at the frontal lobes as well, we are poorly organized and we cannot sustain focus. So it's a very specific kind of attention deficit, if you will, just slightly offline. So let's talk about the two hemispheres. And if you learned anything today, we have two hemispheres and not two brains. I can't stand it when people say the right brain and left brain. I'm like, we only have one brain. Okay, so it's the right hemisphere and the left hemisphere. And about 95% of the population is typical right hemisphere, is about synthesizing creative processes. You've probably heard about this, emotional processing. And then the left hemisphere is more of the analytical, sequential processor, okay? There are some individuals who are flipped, but in general characteristics, this is how we find it. The EEG characteristics here is that the two hemispheres should be relatively synchronous, okay? We really want the left hemisphere just to be a little bit faster than the right. And what we have there is clarity. We can make good decisions, think things through, right? What will happen if I make this decision right now? What are the consequences, right? We lose that with addiction. When the two frontal hemispheres are stable, we're pretty clear on how we proceed with life. When the left side tends to be way too fast, we have increased arousal, too much chatter, and some negative mentation. A little bit like our bipolar symptomology. So when the right ends up being faster, believe it or not, we have symptoms of depression and low motivation. And when the right is slower than the left significantly, we have emotional impulse control problems or emotional volatility, behavioral impulse control. So we look for this when we're doing brain maps. The anterior cingulate is right behind the frontal lobes, okay? So it's not quite subcortical and it's not neocortical, it's almost in between. And the general functions here is our ability to attend to saliency. So it's part of the saliency mode network, right? Attentional focusing. It also is responsible for helping us maintain emotion regulation. The characteristics is we wanted to have a not too much beta. We look at gamma here because of OCD, but we have to have this small ratio here with gamma and beta. And what we're looking for is people who are responsive, open-minded. There's a flexibility there because it needs to be a flexible system. When it's revving too fast, then we have something called a hot cingulate. So if you've read any of Dan Amon's work, he refers to the hot cingulate, and we do too. And these are characteristics of OCD. A lot of our ED patients have a hot cingulate. There's this rigidity, this need to control. They're obsessing on, and everything has to be perfect. It's a lot of stress. People like this don't sleep very well at night. The parietal region and the occipital. What we're looking here is sensory information integration. Okay, so we're body and mind integrating itself. The visual process definitely takes place in the occipital region. That's where we do our seeing, and it's a good indicator of creative intelligence. Okay. Characteristics here is that we should have a theta beta ratio of 2, and then what we have here is someone who can naturally calm their mind. Right? I've had a really busy day at work. I'm stressed out because my boss is being a jerk. I'm going to come home. I'm going to be fine. Instead of I'm going to come home and drink, right? So there's an ability to quiet one's mind. People who do meditation are able to tap into that resource. There's also clarity of thought here, okay? When it is revving too fast, what we have here are anxious manifestations. So these are the folks who can't go to sleep at night, busy mind, those that gerbil again, being busy. And then we also have, when it's extremely fast, physiological burnout. So we can actually start tapping in to see if anyone is physiologically burnt out. And what's interesting is when we meet our patients, we do a brain map with them, and we also do a physiological stress eval. And 9 times out of 10, when this region of the brain is revving too fast, their physiology is fatigued and exhausted. The systems speak to each other, and it makes the patient feel a little less pathological, if you will, right? Their physiology is burning out and they feel it. Alpha, again, and going back to pot smoking, alpha should be a very flexible frequency. It's a bursting frequency like gamma, but it revs a little bit louder, if you will. And the EOEC means eyes open, eyes closed. Okay, so what we were measuring during a brain map is we're measuring alpha with the eyes open, and we say close your eyes. But when they close their eyes, we should expect a big burst of alpha. Okay, when it's a really, really big burst, we ask them, are you pretty creative? Are you an artist? Do you pack a mean trunk? Can you rotate 3-dimensionally? And they're like, yeah. And that's a sign of creative intelligence, that flexibility in alpha. But many alcoholics, when they close their eyes, nothing happens to their alpha, but their beta goes up. And that's the gerbil in the wheel. So they just can't quiet their mind. So we do trainings called alpha peak frequency to stretch that out a little bit naturally. So it's very, very interesting. So again, creative thinking, artistic proclivities, 3-dimensional rotation. Stuck alpha, believe it or not, can be a sign of trauma. And so when someone has an alpha that's sort of stuck and it's big, not low, and so it's when the alcoholic, the anxious alcoholic is a low power alpha. People with trauma have a big blown out alpha, okay? And they're hyper vigilant, they're hyper aroused. They have very fitful sleep. So we talk about that, and if we do see the stuck alpha, we'll talk about any trauma history to see if it's part of their diagnosis. So here's that 10-20 system I promised you. Yay, it's so exciting, right? So this is the nose, this top of the head, there's the ears. So we've mapped this, and this is what, if you go to a neurological office, they're gonna do the same thing, but now we're doing it differently with neurofeedback. And what we do is we take a lead, and we attach it to one of those sites, and it's connected to an encoder box. And I brought my encoder box, that's what it looks like. And from there, it generates information. So this is the nerve, this is a beautiful model of the nerves in the brain. But you can see there are these up and down nerves called the pyramidal nerves. And because whatever fires together wires together, so to speak, these are very good representations of what's going on in a subcortical structure. So believe it or not, you could be measuring at the top of the scalp, you know, you eliminate any noise like EMG or heart rate, and you get a nice clear frequency. You can actually do a pretty good measurement of what's going on in the brain. And this is what we get, okay? So this is just raw EEG, that's combined EEG, and then it's broken down to the left side and to the right side. So these are your beta frequencies here, here's your theta, and you can see the difference in the frequencies. This is another way we look at it, and it kind of looks like that autonomic nervous system I showed you earlier, right? But this is more of a spectral graph of that. And the big peaks is where we have dominant energy. Okay, well, my gamma is now bursting. Do we leave?
No.
She was gonna let us know if we need to
Yeah.
leave. Do you want me to keep talking? Or
Yeah.
should we should we measure brainwave right now?
Yeah.
Okay. So what we're looking at here is that other bit of information. Are we good?
It's a practice.
Okay,
It's done.
We're all awake now. Okay, good. So this is a sample of someone's EEG. So you can see the dominant delta. This is an awake person, right? They're really actually very sluggish, and a lot of dominant theta frequency. So if I were to see this, and I'm dealing with someone with attention deficit, this could very much be someone with attention deficit. I'm going to say, oh, I'm going to need to inhibit that, right? I'm going to squash that down, and I'm going to try to reward this beta region right here, okay? So what I want to show you now is an example of how that works, okay? So this is neurofeedback today. It's really cool. If you have any kids, they're going to love it, okay? But what we have here is we tell the individual, fly your plane through the rain. They have a lead placed here, one lead, okay? This is a typical attention deficit protocol. This green band here is beta, so we're going to try to wake up the brain a little bit by expanding beta. And so we're looking to expand the green bar out between these two threshold lines. Pink and yellow are measuring how much is theta, which is destructibility, and how much is fast beta, which is anxiety or the need to control what's going on. So I'll just show you what it looks like here. And I'll keep talking as it's going on. So there's music attached, and I train with music. Music is attached to the beta frequency here. So when it drops inside, the music will skip. It's one of the best ways to train the brain very quickly. The brain's like, oh, I don't like the skipping. It's going to figure out which wave to increase. They are doing nothing, they're holding nothing. They just have to be aware of wanting to fly through the rain. And of course, I'm talking the whole time saying, when you see this pink bar go up, you're starting to drift. What does that feel like? Be aware of your consciousness drifting. Make that paired association, and then brighten your mind. And it's amazing. They start to figure out how to sharpen their focus with the training. The same thing over here with the yellow bar. When that's above, I say, what are you worrying about? Are you getting frustrated? Be aware of that shift in consciousness and quiet your mind. Okay? fly through the ring, they get excited because they're getting points, right? And so that in itself is a reward. So the therapist is saying, sharpen your mind, what's going on there, listen, and they're sort of trying to get a handle of that experience when they're in the zone, right? Any questions on that? It's pretty cool.
So was that done by someone who was, I guess, fairly good or fairly bad? I'm trying to understand, but that's someone who you've already put through training or had a fairly balanced state, or somebody who
That-
had ADHD.
They didn't do so well.
Yeah,
This
I
one.
spotted they missed.
Yeah.
So
Actually, it's my colleague who, have you met Milan? That was Milan. Okay. He's very sprightly.
Mhm.
He's attention deficit, but he's brilliant. He's one of those,
Yeah,
right?
yeah.
So it took him a while to get that. But this is the kind of training where it's really based on your own progress, right? So someone gets it, maybe 2 or 3 more sessions to rehabituate. But if someone's taking a long time to pick it up, they may need longer sessions. So you always let the brain tell you, right? And of course there's self-report. But I also wanted that to be a good display of not getting it in, then getting it in, right?
Yeah.
All right. So when we do neurofeedback, these are our outcomes. So I think that's hysterical. I'm the only one who ever thinks that's really funny. I don't know why, but it's just a tiny little brain. But really, the studies for neurofeedback began in the 70s, and this is before computer interfaces. So these are with those little gauges and dials, right? And some of the early research was really done on case studies and poorly designed methods. So there is a jury that's still out on neurofeedback that it's actually valid, because they're looking at these old studies that were not very well done. The current studies, they're implementing something called sham. Okay, that's kind of your controlled study. So people are hooked up, but it's pretend feedback. And they're starting to look at people doing real neurofeedback and then the sham conditions, and we're starting to see very significant results and a lot more longitudinal findings. For example, Arns, he's from Germany. He does a lot of attention deficit and depression work, and his patients were staying very well past up to a year in some of his work. So he's doing some outcomes there. With addiction, the early work, and this is interesting because some of the earliest work was done with autism, ADHD, and addiction. Peniston out of Los Angeles developed something called the alpha theta protocols, okay? And he did the work for a very long time, and their theory was that alcoholics had deficient alpha. They had the little gerbil in the wheel. They could not quiet their mind. And so he developed the alpha theta protocol, but they were very poorly designed. He kept switching up, adding some systematic desensitization here, or maybe some meditation there, or maybe something else. And so the findings were always inconsistent. Nobody could tell what was producing the positive outcomes. Was it the alpha theta training? Was it the meditation? Nobody really could put their finger on it. But interestingly enough, the Peniston protocols remain today because they do work. And so the newer studies are being done to show that it is actually more of a robust protocol, and I'll show that to you in a second. So what they're trying to do here is train the natural alpha state, allowing the brain to calm itself naturally. And there's this thing called crossover, and I talked a little bit about it earlier when I said when you're in a awake state but your alpha, your theta goes up, it's kind of like this trance state. They called it the hypnagogic state of reverie. And to get an alcoholic to get to that place while they're awake is very, very powerful for them, because they start to realize that they can quiet their mind naturally. This is also used oftentimes with folks who do a combination of neurofeedback and hypnosis. If you get them in this hypnagogic state, they're open to suggestion. Recent studies are showing that Scott and Kaiser introduced the SMR training into the alpha theta protocol. Has anyone here heard of brain paint? You have? That's William Scott. Okay, so he started out as a researcher. Now he's an amazing businessman. Okay, And that they found out that relapse rates both at 1 year and at early were lower in the experimental group. And we're continuing to do really great work with opiates and alpha theta training. So this is alpha theta training, what it looks like. Here you have the raw EEG, there's that spectrograph. Now this is all delta, so it's a sluggish brain, but it's also extremely busy. Do you see all of that? Lots of beta. This is being measured back here, okay? We should not be seeing that much beta and gamma at the back of the head. So what we want to do here is we are trying to train down fast beta, the chattery gerbil, okay? And we're also trying to encourage this alpha theta frequency. So what we tell the patient is close your eyes, and it's all about making the music as loud as you can get. So music volume is directly connected to this bar graph. The bigger it goes, the louder it gets. The sound of the ocean is inversely connected to this bar graph. The lower it goes, the louder the ocean. So they are given instructions, get the ocean and the music as loud as you possibly can. So you're going to be hearing wah, wah, the volume changing until they can hit that state. And once they hit that state, they start to look like this. Okay, this is actually a real patient, but we've achieved this alpha state, right? The sluggishness is gone, a lot of the beta activity is gone. So they have actually succeeded in that alpha theta training. So how we do it? How are we on time, by the way?
10, 15 minutes.
10,
I want
15
to leave
minutes?
some time for questions.
Yeah.
Okay.
I'll just zip through this because we're almost done. So how we do the program at Sierra Tucson is we have this R4 model of recovery. Basically, and I'm sure all of you do therapy this way, you meet your patient where they're at, right? So even though this is designed, like presented as a stage, it really isn't. But initially, if they're stressed out or they're exhausted, we want to rehabilitate in the moment. We want to stimulate the underactive, quiet the overactive. Then we move into reintegration, which is really kind of that stress management approach. Practice, practice, practice. Rehabilitation is also about practicing with neuroplasticity, retraining the brain through practice, upward conditioning, leading to a state of resiliency. So that's basically our model. I mentioned this earlier, every patient gets a brain map and the psychophysiological stress evaluation as their first appointment, because I believe in the body informing us. The next session is we go over the findings and we find out what's really going on in their life. And then they get to retell their story through their physiology, understanding what psychophysiology is all about. And then we plan the treatment based on that. So rehabilitation is just bringing back to normal, healthy condition after an illness. And that is what we talked about earlier. So we do the breathing techniques. I have that slide on there. We also will incorporate some passive neuro techniques. And these are some of the neuromodulation devices that are open to most of the general public. Audiovisual entrainment, transcranial direct current, and this is also known as alpha stim. Are any of you familiar with these? They really do work. I've tested them in our lab to make sure that they do, because I'm a bit of a skeptic. But this is really tapping into the sensory systems. Strobe and binaural beat helps shift the brain. Max has tried them before, and it worked for your jet lag, right?
Oh, machine, yeah.
And he loved it. He came to me after coming to Arizona. He's like, "Give me the machine." So, and here is transcranial direct current. It's not the same thing as ECT at all. It's taking a milliampere of electricity and gently nudging or stimulating and and quieting another part of the brain. It's wonderful. Reintegration, stress management, and this is where I like to think the integrative biofeedback really integrates with the body. And so this is where we actually do combine training with heart and brain. There are many protocols that incorporate heart rate variability to SMR training or sensory motor strip training, because of that vagal nerve connection between the heart and the limbic system is very powerful. Rehabilitation is really the gem of bio-neurofeedback. And this is where we're helping someone move out of a stuck psychoneurophysiology, retraining the body and brain to regulation training. And resiliency, really, that's no training for this. This is really allowing yourself to become part of that flexible homeodynamic, calm yet alert state. The natural state, and this is tapping into one's resources, right? That they have naturally within themselves areas to help cope in their own recovery. They just have to learn how to tap into it. And that's one of the things that we do here. Ninja Mind is what I use with my young addicts because they like it. And we do a lot of the flying stuff, and they brighten up when they do it. And so it can be a lot of fun, neurofeedback. It doesn't have to be hard work. So what we do is we serve to complement the integrative therapeutic process here at Tucson. Key thing is education. We help patients realize that psychophysiology is real. Their emotions, their addictions are manifested through the body. And we want to coach and train patients to reestablish their own homeodynamic state. And a lot of times they feel very empowered. And it's a little bit of a relief that they are not as pathological as they think they are. They're responsible for all of their problems. Once they start to learn that they can change their own physiology, there is an automatic sense of empowerment. It's very healing. This is a part of an article that I wrote a few years ago for one of the journals for Biofeedback. And I basically say when sessions are experienced in this cumulative fashion, our aim is through reintegration and rehabilitation, body and mind have transformed toward resiliency. Patients become in tune with and appreciate the dynamic nature of their own body and their own neural rhythms. This may contribute to metacognitive expansion or profound insights. We often observe, and we see these insights take place when they engage in bioneurofeedback. And I think it's the essence of this profound mindful awareness when delivered in an integrative, dynamic way. So that's pretty much it in a nutshell. And he says, Mr. Osborne, may I be excused, my brain is full. So, any questions? Yes, ma'am.
I was reading, so you talked about the biofeedback and you talked about stress.
Mm-hmm.
So, like, how would that, by stress, does that include anxiety? And, like, what about, like, early trauma? So, would all of that come under the
Absolutely.
umbrella of stress? So, it doesn't matter what the cause is, it's just stress.
It's a different perspective, right? So it depends how we've been educated. Is it through the ICD-9? Is it through the DSM? When I, as a psychologist myself, I now see psychopathology differently. I see it through the rhythms of autonomic nervous system or the central nervous system. And stress is a huge, huge factor in everything that we deal with, especially trauma, right? A traumatized individual will definitely have a stuck physiology, right? They're going to be in a chronic stress state, and they have to be because they're waiting for the shoe to drop. So they've trained their body to be in that state of tension.
And how would you know with your client in front of you who's got a stressed brain, how would you know is it have EMDR or have neurofeedback or have SE or with so many tools now, how do you know, or just to have good therapy or to have therapy, long-term attachment therapy?
Right.
Do you make your
How do you make your decisions?
Mm.
Well, I think the decision has to come from the patient, and I think that's why integrative mental health is good, because it's really the therapist-patient relationship. You know, and EMDR is fantastic for trauma, but not everybody's ready to do it. And so I think a good therapist will have an understanding of if they're ready to be grounded and have their resources in place in order to do that. Same with SE, right? Sometimes people are not ready to tap into that. A lot of times people are not ready for bioneurofeedback either, right? So you have to find out where they're at. We do have the brain map. We do the physiology. So we bypass the self-report. We go to the body first. Then we bring in the self-report. And oftentimes the patient will tell us. And then of course if they're succeeding, they'll do a session. They move out of chronic stress into homeostasis. They're starting to experience what that feels like. A lot of times they say it's like prickles or heat, like a flow of heat. People have different sensations. Or maybe they feel clear. Their mind is clear. They make the paired association. So it depends on how well they do and how much they are mindful of that shift. If that helps or not.
Nice.
Yeah. Anyone else? Yes, sir.
NARM.
Nom?
Yeah.
Vietnam?
No, NARM as in NARM.
Oh.
The neuroaffective relational model. How is that fit that people are talking about? To what does that overlap with all of this?
Neuroaffectional.
Affective relational model. A lot
I've
of people
not
in the
heard of
States are
NARM.
setting it along with SE.
I need to.
And it's called
NARM.
NARM.
I'll have to look that up.
Okay. I just wondered if actually it's the same thing but just packaged
Tell me,
differently.
God help us, right? Well, what is norm? What's the theory?
Well, I don't completely know, but I think it is some sort of feedback. It's some sort of neurofeedback. So I'm wondering if actually when people.
Relational, yeah. I'll have to look into that.
Yeah.
Developmental trauma?
It's often packaged with SE.
Is it?
Yeah.
Mhm.
I'm just wondering to what extent it's connected.
Well, especially in SC, there's a lot of focus on childhood trauma, right?
Yeah.
And there's cumulative adversity, which is another fancy way of saying chronic stress over time. And so they're doing some brain studies around that. So I'll have to look into that. I'm wondering if it isn't just an iteration or reiteration.
Yeah, that's what I wondered.
It's
It happens.
Hella. It's called Hella.
Hella?
It's one person who's developed it.
Hella? I'll look it up. Thank you. Anyone else? Yes, ma'am.
Firstly, I just want to say I think this work's amazing.
Thank you.
So I'm so glad I managed to come and listen to what
I
you
know it's the
have to
last
say.
session of the day.
I know, I haven't got much brain left, but I tell you, I was really engaged. I'm 20 years in recovery from chronic fatigue syndrome, and so I know a lot about a lot of things you were talking about made perfect sense to me, and I wish I'd come to your place and had that kind of work. I think it would have helped me. But one of the ways I got well was using amygdala brain retraining techniques, which took like what you shared actually, I was in a state of chronic stress because of trauma and other things, and that was creating the chronic fatigue syndrome.
Exactly.
So basically retraining the amygdala was basically training the pattern that my amygdala fear center was in to come off a fight-flight response, which was my body's chronic stress response.
How do you do that?
So it was calm, it calmed down. So I did it with a practitioner.
Was it
It
through
uses a
neurofeedback?
Sorry?
Was it through neurofeedback?
No, it was actually through a guy who put a bunch of techniques together, including NLP, and came up with this process that you could do of interrupting the patterns on an unconscious level and retraining the brain out of the stress state.
Fantastic.
So as I'm listening to what you're saying, I guess what I'm wondering is if I continue to do the work actually, just because I want to get to a much more even optimum state of health, and I feel like nervous system recovery is the core. Do you think that doing that retraining, so basically training my brain out of that hyper responsivity to input to make it get into the stress state, the brain balances you were talking about, I tried to take as much of it as I could, beta and all of that. Do you think it stands to reason that if one retrains one's amygdala out of being in constant fight-flight back towards the homeostasis that you described, that those balances would start to naturally take place as part of a person's natural healing process? That's what I'm wondering.
Absolutely. Absolutely. Because we are remarkable creatures. We're designed for balance. We are.
Right.
And I often say my job is really to nudge, right? So if I work the other thing I say is I like to work myself out of a job, right? Because then I know that it's working. Because we just have to nudge the system, and it knows what to do. And that's the beauty of the self-parent conditioning principle, right? So you might have trained because of the exposures you had in your life, right? With the traumas and the chronic stresses and the demands, your brain beautifully geared up to deal with it. But then your life might have balanced out, but your brain was still operating in survival mode. So we have to, over time, train it back. So this, whatever it was that you're doing, clearly was effective.
Thanks.
You know?
It's really encouraging.
Yeah.
I don't have the knowledge and the equipment and everything that you do, but
Yeah.
I really want to use that training that I've learned
Keep
to
doing
help
it.
addicts recover and to help them. And actually, so if that can even help on a small scale to people that don't have access to this great stuff you talked about,
I
that's
think
quite
so.
encouraging.
Yeah, I think, I oftentimes think that therapy is part of neurofeedback anyway, right? This is cool stuff. You get to play games with your brain, right, or your body. But isn't learning a neurofeedback process? I mean, the whole notion of learning something is in getting the brain to learn a new pattern, right? So we don't have to measure it to know that you've succeeded. It's like riding a bicycle, right? Your body and brain just know how to do it, and they don't forget. So I think the process of therapy itself, it may take a little longer because you're not really targeting specifically, but you're still going to get to the end point. And why not learn a little bit of neurofeedback in your own practice, right?
There's
So
hope
that's-
there, isn't
yeah.
there? There's so much hope.
I
think it's fascinating as well because it strikes me that oftentimes it comes down to us as human beings, as animals, mammals, forgetting how much we don't know and staying so much on what we do know, which is infinitesimal, it's tiny.
So true.
But we become so focused on that I think we actually allow the rest of what we would be doing naturally to not happen. And I mean, you mentioned Dan Siegler about neural pathways developing, I mean, a lot of mindfulness and a lot of the exercises turning the sort of arrow back into oneself again. And then, actually seeing the neural pathways in the brain developing over time. And very much this idea of practice makes permanent.
Right.
I don't know if you're aware of Dr. Bob Rotella, are you?
No.
Well, he's mostly known for golf, actually. He's also a psychologist, but it made a profound impact on me because he was just saying, and it seems to me an essential principle in any therapeutic approach, that it is practice that makes permanent. That's what lays it down. It doesn't make perfect because you can be doing the wrong thing. And that's what he says in the golf swing, that's incidental.
We don't like perfect because nothing's perfect.
Absolutely.
Perfectly imperfect.
And his book was, Golf is not a game of perfect, but actually you can apply that to psychological living and saying, well, that actually is a bigger truth, it's a bigger philosophy that it's more about what we do, and if what we're doing is dysfunctional, well, we lay down those neural pathways, and that becomes the way that we hardwire ourselves.
We are habitual systems.
Yeah.
That's what we do. We're like puppies. The brain is a puppy. If you expose it enough over time, it's going to habituate to whatever that is, right? And I tell patients, our number one function of the brain is to perceive. That's what it does first. It perceives, and then it informs, right? But it's a perceptive tool.
But we're biased towards thinking it's the confirmation bias, isn't it? We always think that we're right.
Of course.
Because that's the pressure that's put on us. So the ego that we develop is how other people are telling us about ourselves. And if they're constantly praising us, then we've got this tremendous idea of self where we're always right. Even when it's clearly not rewarding us terribly.
They have a hot cellulite, that's what they're called.
Right, yeah. But I think it's fantastic. I echo the other here. It's a brilliant, it strikes me as an absolutely brilliant, very engaging form of psycho-ed in many ways, isn't it? Because you really are saying to people, look, actually, whatever you might think, this is what's happening. And I mean, I find with a lot of clients of mine that offering that to someone in addiction, a group of addiction, it's very much sort of gabble matter. It's not a character flaw, it's not a personality defect. It's the response of the brain that's been formed through circumstances which were not in your control. What you do have control over is what you do now. And I mean, that seems to be a wonderful offering to the clients who are sort of, you can almost see them kind of engaged and they think, oh, okay.
Because most addicts feel like they are at the mercy.
Yeah.
They have no control. They're at the
That's
mercy
right,
of
they feel
this.
re-empowered by
People
being
with depression feel the same way. They're at the mercy of their depression. And when you start to show, this is a function of your physiology, right? And you just showed me 5 minutes ago that you got out of stress.
Yeah.
And they're like, oh yeah, I can do that, right? So it is extremely empowering. So it tends to be more on the positive. And that's why I think I personally like what I do so much, right?
Yeah, sure.
It's not about pathologizing, it's about showing your own resourcing that you have available.
There's still a lot of prejudice against. I mean, today, just at one of the presentations, Tim Layton was actually a little bit scathing about it. If anyone tells me it's the brain one more time, I'm going to get really quite, and I sort of thought, well, it's a tool in many ways, isn't it? The brain's an organ. So I mean, if you're talking about it and referencing it, showing it, and it's helping, what's the problem?
Right, exactly. But we have to put it in its place. It is a function of the problem, right? And so like the NIDA definition, that addiction is a brain disease, I cringe when I read that because it's only part of the process, right? I actually think the heart is really running the show, but don't tell me when I said that. You had a question, ma'am?
What happens with your patients that go home who've responded really well to this? And say they're coming back to Europe and I don't know what we have here. How do you manage that aftercare?
Well, the nice thing is BCIA, so the Biofeedback Certification Alliance Institute, which is international, They have a resourcing page. So if you put in the postal code of your patient where they live, it will show you certified practitioners. So oftentimes, so I make a decision after training someone if they really do need to continue on, because we have them for 30, 40 days, and maybe I see them twice a week if they're lucky. So sometimes they need more training, and so I'll find a list of providers and then I'll encourage them to go and continue the good work. Sometimes people are fantastic, they get what they need to get, like you were asked, and they don't really need to spend that kind of money, and I may encourage them to buy the ABE device, and then they can just keep the brain tuned, if you will, and they're good practices. It really depends on the individual, but it's bcia.org, and you can find practitioners who've been certified and by our neurofeedback.
I've got one of those machines. It's about £500. It's great.
Thank you all so very much. Thank you for staying.
Thanks very much.
Thank you.
That's brilliant.